Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you for the best opportunity to participate on the 6th International Conference on Biophysical Technology in Dentistry. I'd like to quickly introduce myself. My name is Faisal. I'm resident of Oral and Maxillofacial Surgery, Hasanuddin University. The title of my presentation is The Treatment of the Temporomandibular Joint Dislocation During COVID-19 Pandemic. This is result for 8 patients in Central Sulawesi Tertiary Care Center. First, I would like to talk about the background or introduction. The temporomandibular disorders are a class of chief compliant and clinical manifestations involving the temporomandibular joint, the masticatory musculature, including surrounding bony and soft tissue components. The 3 most common temporomandibular disorders are myofascial pain and dysfunctions. Second, degenerative or inflammatory joint disease, osteoarthrosis. And the last, the temporomandibular joint functional rearrangement, including mechanical interference, restriction of the normal movement, or hypermobility disorder or dislocation. The first picture shows the anatomy of temporomandibular joint. We can see the head condyle, glenoid fossa, articular eminence, the temporomandibular joint's coronate process, ramus and mandibular notch. The incidence of TMJ dislocation case is 5.3 in 100,000 emergency and account for 3% of all documented dislocations. The survey, which conducted in Germany, found that at least 25 per 100,000 population each year. TMJ dislocation is a condition in which condylar process does not reverse and dislodge from its normal positions in the glenoid fossa to articular eminence. The temporomandibular joint dislocations characterized by painful limitation of joint mobility. Second, the impairment of speaking and chewing. And last, there is inability to close the mouth after wide opening. This is the illustration of temporomandibular joint. The first picture we can see the condyle is in the glenoid fossa, and the second, there is anterior dislocations of the TMJ. The positions of the condyle is anteriorly displaced from the glenoid fossa. The basic symptoms of the temporomandibular joint dislocations are inability to close the mouth and impaired occlusion, which associated with pain. We can make an accurate diagnosis after confirmed by radiograph. They are plain radiograph, CT or MRI. If plain radiograph shows inadequate views, CT scan modality can be used to help evaluate the temporomandibular joint. Temporomandibular joint dislocations can be classified into acute, recurrent, or chronic condition. TMJ dislocations can be anterior, posterior, medial, lateral, or superior to the glenoid fossa. It can be also classified as partial or subluxation condition when the condylar process reducible spontaneously to the glenoid fossa. Complete dislocations or luxations when one or both mandibular condyle remains dislocated. The other classifications, according to the Kimbemi, had been divided the temporomandibular joint dislocation into 3 categories. Type 1 defined when the condylar exactly under the tip of the articular eminence. If the condylar position in front of the tip of articular eminence, it is classified into type 2. And for the type 3, it is the same condition with type 2 with the higher position. The primary objective of treatment for the temporomandibular joint dislocation is to restore the normal positions and function of temporomandibular joint, reduce pain, and increase the patient's quality of life. The management of the temporomandibular joint dislocations can be classified into conservative treatment or surgical approach. Early conservative treatment by manual reduction technique with or without sedative or local anesthetic is the best approach for acute treatment and can give optimal results. Sometimes intravenous sedation and muscle relaxant are needed for reduction of mandibular dislocations due to muscle spasm with the temporomandibular joint. The treatment may intensify with supportive bandage and soft diet for the patient. On the other hand, surgical approach is considered for chronic conditions. There are several manual reduction techniques. They are Hippocrates, extraoral, the rice pivot, and recumbent technique. In this series, we present 8 cases of temporomandibular joint dislocations were identified and treated in Central Sulawesi Tertiary Care Center in Undata Hospital. The cases were identified during pandemic from March 2020 to March 2021. The dislocations occur through a variety of mechanisms, sometimes due to trauma, while opening after yawning and shouting. For the demographic illustration of our cases, there are 2 male patients and 36 years old mean age, compared with 6 female patients with 40 years old mean age. All patients in this case series presented with the chief complaint of inability to close their mouths. All 8 patients were successfully treated with manual reduction with recumbent technique or supine position technique. In our hospital, patients presented in emergency unit were screened if the patients have atypical symptoms as seen with COVID-19. After screening, patients which categorized with non-suspect case confirmed by rapid antigen test. It is performed in all of our patients in this report, confirmed with negative result for SARS-CoV-2. In this discussion session, we can conclude that temporomandibular joint dislocation is debilitating condition and decreasing the patient's quality of life because the pain, discomfort, and prohibited the mouth movement. Of course, this condition needs urgent and rapid treatment. The patients with acute TMD dislocation should be treated with manual reduction. The treatment of acute temporomandibular joint dislocation with manual reduction can initially without administration of any medication, but if the attempts did not work, we can perform the reduction under medication such as analgesic, muscle relaxant, sedation, or general anesthesia. The recumbent technique or supine position technique provides adequate vision of intraoral and dynamic occlusion of the patient. Finally, I would like to close these presentations and thank you for the attention.